Before we get started with the individual session, I'd just like to say a few words about the track. I'm Richard Lang, and with Dr. Batul Jaffa and the members of the track committee, we've tried to organize the track in such a way that we maximize the opportunities for exchanges. So all of the tracks have only 4 presentations in them, so we'll have a lot of time for discussions. Auki Mantel, sitting here, will be a co-rapporteur for all of the sessions. And so whoever is the rapporteur will work with her to try to bring it together as far as that goes. So if there are things which you would like to have included that you don't have time in the track sessions, in the discussions to point out, please speak to Auki about it as well, or to me, and write down a quote and so that we don't lose any of the discussions. We will have a lot of time on the Friday to go through the key messages and that. So as you're hearing the sessions, please note down anything which you think shouldn't be forgotten. When I teach courses, I talk about click moments, key ideas that you hear. It may be unique to you. Capture that and keep it so that when we come to the discussions on Friday, we can include those in the sessions. So thank you all very much, and thank you, Regina and Andreas.
Thank you, Richard, for that introduction. Good morning again. My name is Regina Mbindio. I come from Kenya, and we are moderating together with Andreas. You met him in the plenary session. And it is now my pleasure to invite the first presenter for this session, who is Debra Rowett from the Drug and Therapeutics Information Service in Australia. And the paper to be presented is Improving Access and Quality Use of Medicines in Palliative Care within National Drug Policy, Regulatory and Funding Frameworks. Welcome, Debra.
Thank you very much. And thank you to the organising committee and the scientific committee for allowing me the opportunity to present this work on palliative care. I know within the many constraints of the public health and in many countries, just funding disease-modifying and prevention therapies. And so as perhaps the only paper in this meeting on palliative care, I would like to present it within the context of my colleagues who have been working with me in this area. And just by way of background and setting, clearly palliative care has grown significantly in the last 30 years, and it has been progressively implemented within national health systems, and WHO has provided a lot of the framework and impetus for that. And in some countries, palliative care is recognised, however, only in the context of certain chronic diseases such as cancer. But for many countries, it has not been integrated within the health systems. But I'd like to suggest that there's a growing need for even more attention for palliative care throughout the world, particularly with an ageing world population and increasing incidence and prevalence of cancer, HIV and AIDS, and also progressive advanced chronic illness. And this is affecting all countries of the world. If we just take this example from the sub-Saharan Africa, where in 2009 it was estimated that there would be 22.5 million people living with HIV, AIDS, 67% of the global disease burden, but also over 700,000 new cases of cancer and 600,000 cancer-related deaths in 2007. And if you take the WHO's estimation of the need for palliative care as being 1% of a country's total population, then approximately 9.6 million people are in need of palliative care across Africa. And if you couple that with the statistics on the ageing paradigm, 29 million older persons may be added to the world's population each year between now and 2025. And 80% of that will be added in the developing countries. And it's projected that by 2050, around 80% of the elderly will live in the developing world. And the burden of disease will be non-communicable disease and chronic disease. So this increasing longevity will have far-reaching consequences for the provision of palliative care for all countries of the world. So thinking about the context of palliative care in terms of policy development, most of the work has come from the cancer areas, and in Australia, the work that we've been doing has been looking at integrating both our national medicines policy with the National Palliative Care Strategy to facilitate community availability of key medications in palliative care. And part of the motivation and momentum of that is that with this growing ageing population and increasing burden of chronic disease, to facilitate a good palliative approach within the community, these people are going to need to be managed in primary care. So our National Medicines Policy has 4 central objectives: timely access to affordable cost of medicines, appropriate standards of quality, safety and efficacy, and quality use of medicines, and also maintaining a responsible and viable medicines industry. Our National Palliative Care Strategy has also at 3 key areas around medicines: improving access, raising awareness within the primary healthcare workforce of existing medicines that are available to manage symptoms in palliative care, and importantly, that responsibility that comes with improving access, and that is to promote the quality use of palliative care. Importantly, to integrate these 2 policies at a national health level, a palliative medicines working group was established with a range of stakeholders, including industry, medicine, our National Prescribing Service or NPS, to facilitate the discussions, and a broad range of stakeholders, consumers, the Palliative Care Australia, many members, around 20 members of this group, to debate and discuss the issues to take this policy forward. But improving equity of access and quality use of medicines in palliative care is, however, impeded by the limited evidence for efficacy, cost effectiveness and safety. So in terms for advocating improved equity of access, we are limited in terms of the evidence base underpinning some of those decisions. Many of the medicines are off-label and have off-label indications, or they're old drugs where there's not been motivation for doing more work in terms of understanding what their role is in relieving symptoms. And we've already heard a few times today that premise of first do no harm. In terms of advocating for medicines in this area, for some of those we're not sure of the benefits or indeed the harms. So prescribing at end of life, we also need to think about adverse drug event burden, and pharmacovigilance in this context is an area that there has been very little study that's been undertaken. And an important area if we think about the avalanche of people that are going to be, I suppose, in the setting where palliative care might be applied. And many of those people will have other chronic diseases, and it will be increasingly difficult to differentiate the pathology of the disease from adverse drug reactions or adverse drug events that might occur. So as part of this policy initiative and having the large number of stakeholders involved, our government funded an initiative to look at some of these issues, and this just provides a bit of an overview of the structure, where you have a management advisory board, a scientific committee, a trials management committee, data safety monitoring, and phase 4. It looks a little bit familiar, doesn't it? But this has been entirely funded by government, and there are all investigator-led studies on old drugs where there's not been the research done. So a structure has been established and has been funded by our federal government and continues to be funded. Initially there were 6 sites involved across 5 states in Australia, and involving prospective phase 3 clinical trials and also phase 4 pharmacovigilance work, and also the development of consumer impact statements on medicines. Further drug utilisation methodologies to support ongoing monitoring of drug use are being developed as well. And so what this highlights in this approach is that the health policy was integrated between the palliative care policy and the national medicines policy, but it came with the commitment from a large number of stakeholders. But what it identified was that there was need for further information to inform that policy, and we needed good data both on efficacy but also in the area of adverse events if we're to take this forward. And one of the key areas that we have a responsibility in terms of improving access is also this monitoring and follow-up in terms of efficacy and adverse effects, but also in this area of palliative care is ensuring that alongside of those policies we are cognizant of the risk for diversion and unsanctioned use, and so those policies need to be developed in concert with this approach that's been taken in Australia to improve equity of access so that clinicians and patients can choose the place of palliation. Thank you.
Thank you very much, Debra, for that very concise presentation and for sticking to the time allocation. I believe we'll be taking questions at the end of all the 4 presentations. So we will, I think, move on to the next presenter, and Andreas will introduce the next presentation. Thank you.
Okay, next presentation is from Jennie Leitz. Jennie is with the Ministry of Health and Social Services in Namibia. Am I right? Okay. Jennie, please go ahead.
Good morning. As mentioned, I'm Jennie Leitz, Deputy Director for Pharmaceutical Services in the Ministry of Health and Social Services, Namibia, and I'm presenting this morning on the use of an indicator-based system for assessing, monitoring, and improving pharmacy practice in Namibia. Okay, I don't know how to use this thing. Right. To start with a bit of background about Namibia, for those of you who don't know, Namibia is a large, arid country in the southwest of Africa, 824,000 square kilometers. You'll see there it's bordered by Angola in the north, South Africa in the south, and Botswana in the east. We have a population of about 2.1 million people in this country that is 4 times the size of the United Kingdom. The Ministry of Health and Social Services serves about 85% of this population's health needs. Namibia is ranked as an upper middle income country, a fairly new issue for us, which is bringing us some problems. However, Namibia has a high level of income inequality with a Gini coefficient of 0.7 or 70%, so that's one of the highest in the world. We have a high HIV prevalence, approximately 13.3 in the general population. Now some background on the public pharmacy services. The Ministry of Health and Social Services has got a centralized supply system for pharmaceuticals to all public health facilities. And we have a current annual expenditure of approximately $50 million on pharmaceutical and related supplies. We have a severe chronic shortage of trained pharmacy staff, which is quite common in Southern Africa. We have just started our first pharmacy degree course. The first intake was in 2011. Being a small country with a small population, it's been a struggle to start a medical school and pharmacy school, but we hope this will help with the future of pharmacy in Namibia. We've done 3 national medicine use surveys. Those were between 1997 and 2001. And although they showed improvements in a couple of areas, including labeling of medicines and use of generic names, most of the indicators did not show any improvement, and some were actually getting worse over that time, including increasing use of antibiotics. We have high availability of essential medicines, generally over 90% in our health facilities, but we have strong evidence of inappropriate use. So we need to look at how we can improve this situation, given the resources that we have to make most use of them. So we identified in 2002 that there's no mechanism for consistent reporting of pharmacy services. Having medicine use surveys is one way of doing it, but it's very labor intensive and every couple of years, and it only takes a sample. So we wanted to improve on that. So the intervention that we did was to implement a ministry-wide pharmacy management information system. We developed the system through wide consultation in the whole ministry, and we developed a system that includes data collection tools, data collection and reporting schedules, as well as a feedback system. The data collection tools collect information from, I think it's 21 different indicators at health facility level. And currently, we're working on expanding this, so we'll also collect data from national level as well for various areas. At the launch of the PMIS, we trained regional pharmacists on the system, and then they were responsible for training the pharmacy staff in their regions. We've also worked on strengthening therapeutics committees so that they can take on the role of designing, implementing interventions to address the gaps they find in their own district and own regions using the PMIS data. Also, we've had implementation of the system is ongoing through data collection, quarterly data collection, analysis, and then use of the data at all levels, district, regional, and national level. And we have feedback through quarterly national PMIS feedback reports, as well as feedback from regional pharmacists to their districts. So just some key results. The PMIS was formally launched in July 2007, having been working on this issue since, I think it started in 2004, we started building the system. All 34 hospitals in the public sector produce quarterly reports, and they are forwarded through their regional pharmacists to national level. We have a national database that's been developed for tracking performance by the hospitals in the various areas, the 21 indicators. Some of the indicators are quarterly, some are 6 monthly, and some are annual. So it's not 21 indicators every quarter. PMIS data and results are discussed at district and regional therapeutics committees, and interventions are implemented at those levels as well. And the division Pharmaceutical Services, where I work at the national level, produces the quarterly report that then distributed not only to the districts and regions, but also to the senior managers, so they are aware of the key issues. Looking at some notable national results, I haven't put all 21 indicators because it'd be a bit much, but these are ones where we've shown some good improvements. The percent of facilities with all key items in stock went up from 91.8% when we started to 97.8% at the end of the financial year 2010-2011. Percent of stock cards balanced the same as physical stock, something we've been battling with since I've been in Namibia. Since 1996, we've been struggling on this issue. We'd improved from 75% to 91%. Percent of days in which temperature of the main store was below 30 degrees, 67% increased to 94%. That may sound like we spent a lot of money on air conditioning, but what actually it was people to measure the temperature. People were not measuring the temperature in their store. We know it's meant to be below 25, but we live in a very hot country, so we reckon 30% is okay, considering how long we expect them to keep their stocks for. Sorry, 30 degrees, not 30%. Percent of prescriptions prescribed by generic name increased from 62% to 87%. And percent of therapeutic committee meetings held out of plan increased from 40% to 72%. This is really a key area, because if the therapeutics committees don't meet, then they don't discuss the results of the PMIS and they don't implement any changes. We've also had notable interventions in the different regions, because one of the key issues that we wanted with the PMIS was to give the power to the districts and regions for them to make changes themselves, not to wait for someone from national level to say there's something wrong and come and help them. So we've really tried to empower the regions. A development of a list showing brand and generic names of medicines in Ohanguina region has improved their generic prescribing considerably. Rational medicine use trainings were carried out in Konene region to address prescribing problems identified using their PMIS data, namely polypharmacy and inappropriate antibiotic prescribing were the main areas of problems. Inventory management trainings have been conducted in Kavango region, and they've improved the adherence to standard operating procedures for inventory management. Use of PMIS workload data, it's been used to successfully motivate for additional pharmacy staff in Hardap region, which is very key for us. And based on PMIS findings, Ochozonjupa region carried out operational research on the antimicrobial resistance of UTI, and they've designed new guidelines to manage UTIs in their regions. And of course, we will take note of that from national level because it's an indicator that probably our current guidelines were not up to date. Moving on to lessons to be learned. First of all, wide consultation is essential in the development of any management information system in order for all stakeholders to have ownership of the system. I actually tried to initiate an initial version of PMIS back in 2002, and it didn't succeed because it didn't have wide stakeholder consultation, and also there was not the staff at national level to follow up. I didn't put that as a bullet, but that is also key. What was highlighted this morning about having a team at your national level in your Ministry of Health looking at medicine use, that has been very key. We've increased the number of staff at national level through support from MSH, and this has enabled us to do the follow-up, to implement and assist the regions. So that has been key as well. Implementation of the PMIS in the ministry has strengthened monitoring and supervision of key aspects of pharmacy services. It brings a bit of competition between the regions and the districts. They want to be seen to be doing well. I've been asked from people looking at my poster already twice that, how do you get the people to submit? It's like, well, we follow them up, which you need staff for, but when they don't submit, then when the report comes out, such and such region didn't submit, no data. On every single table, no data, no data, no data. Then their regional director takes note. Then their regional director stands on the regional pharmacist, and things improve. So it does move things forward. The improvement has been done by providing practical tools for data collection and reporting. It empowers the managers at district, regional, and national level. Having a national system has also raised the profile of pharmacy issues in the ministry, bringing problem areas identified through the PMIS to the attention of regional and district management teams and also national managers as well. And the national level uses the results from the PMIS to identify districts and regions needing additional support, as well as ensuring equitable distribution of resources. Implications of the work done, the PMIS has had considerable positive impact on the use of medicines in Namibia in the 4 years since implementation. These positive impacts are expected to continue and increase with time as systems are strengthened, especially the therapeutics committees at hospitals and regions. That is a very key area we want to continue strengthening. The therapeutics committees are essential to the success shown from the PMIS. They provide a platform for discussion of problems identified, as well as overseeing design and implementation of the interventions. Before implementation of the PMIS, as I mentioned, we were doing the national medicine use surveys. We did 3 of them. And they required a high level of staff and financial resources, higher level of staff and financial resources than we need for our PMIS. But in the end, we didn't really see many significant improvements based just on a survey. You have to do a survey and then implement something. Now, this is putting the implementation in the hands of the local staff and the regional staff. So in conclusion, the PMIS is an effective and cost-efficient way of assessing medicine use situation and has resulted in improved use of medicines in Namibia. The PMIS has proved to be more beneficial than conducting the national medicine use surveys in terms of improved outcomes as well as reduced HR and financial requirements. Other countries should seriously consider implementing such a pharmacy management information system in order to strengthen management of pharmacy services and improve use of medicines and health outcomes. The end.
Thank you, Jennie. I have one question for understanding. So sit down, then you can use that microphone here. How many data collection points do you actually have? I saw on the one slide you asked about, you mentioned the hospitals from which you collect the data, but how far down do you go to the health centers, health points, and so on with this data collection system?
We started just at the hospital level, but we're rolling several of the indicators down to the clinics and health centers. So actually, I couldn't tell you offhand the exact number, because we're encouraging regions, more and more regions are collecting data from their clinics and health centers as we move forward, but it's not all of the places yet. Namibia has about 300 clinics and 45 health centers, as well as the main 34 district hospitals.
Okay, thank you. This is important to understand, like, let's say the quantitative dimensions. I have one, we discussed one issue here in terms of the timing of the session. I think what we want to do is have the discussion with everybody involved after we had the 4 presentations, but the original plan, according to the agenda, is that there's a break in between. Now, I think in particular in this large room, if we all march out after 4 presentations and then hopefully come back after half an hour for a discussion, we don't think it's a good idea. So we would like to suggest that if you are craving a cup of tea, just sneak out, get it, and come back. And we would like to continue for 2 hours with the 4 presentations and then right after go into the discussion. And again, I would encourage you to come down here so that I'm not even sure that we get microphones, but the people with the microphones, they get tired when they have to run all the way up to row 25 and you have a question back up there. So, okay, next speaker.
Okay, thank you very much. From Namibia to South America, we invite Rene Soria Saucedo to give us a presentation on the retail market, the share of generic medicines in retail market, a comparison between 2 countries. Welcome, Rene.
Good morning. It's a great honor to be with you today. First of all, I want to take the opportunity to acknowledge these events organizers and the co-authors of this study. Thanks for your support. Well, moving on. So, what was our main purpose to do this study? I'm coming from a very research-oriented organization in Mexico. So we were very interested to know the links around generic market share and policy implementation, if there were any. So we tried to analyze the relationship between the volume share of generic medicines in Mexico and Brazil between 10 years, 1999 through 2009, and public policies to promote their use. So our study design included probably the most developed countries in South America, Brazil and Mexico. I have to be very emphatic and to share that we were analyzing the retail market only. And what's going on in the public sector is a completely different story from this research. However, taking into account that at least 2/3 of both countries' population cover their health needs with out-of-pocket expenditure, this information is relevant. Our methodology was constituted by 2 segments. The first one, a quantitative analysis, a time series analysis of the retail pharmaceutical market volume. We used IMS health data, and a qualitative approach of public policies assessment regarding promotion of generic medicines and a literature review. So about the data analysis, we took into account the total annual sales volume in the standard units and stratified by originator and licensed brand, branded generics and unbranded generics. I'll explain that later on. And we use only retail data, and that's about sales volume. Our qualitative approach we use narrative analysis techniques to find meaning of the literature under the premise that our findings should be empirically founded. So we were particularly interested in looking for agencies and organizations in charge of policy implementation, mechanisms used to increase generic uptake, role of the national pharmaceutical industry, and differences between the policies implemented in the public and the private sector. So our results, here you have the graph of the Brazil retail sector. It's divided in 3 segments. The bottom segment, this one, is showing the original and licensed brand. So this is the branded medicines. The second segment of the graph is showing the other brands. That's branded generics, similars, copies. So it's a very wide approach of what kinds of medicines are in this segment. And the segment at the top is including the unbranded, so that's the generics, the interchangeable generics. We have to remember that Brazil and Mexico are one of the first countries in Latin America that took into account bioequivalence studies in order to prove generics. And the first thing that comes to mind when looking at this graph is the progression of the top unbranded. So it's a linear correlation that is showing at the statistical analysis. We have a 5-fold increase from 1999 to 2009 of the generic entry and utilization in the retail sector. Another thing of interest, the first thing of interest in this graph comes to mind when we're looking at the period 2000-2001, because this was statistically significant, the difference in the increase of the generic entry. So we linked some hypotheses that we have regarding this. So we hypothesized that the increase was related with the entry of the official regulation norms of the Brazilian national drug policy. The Brazilian drug national policy was implemented in 1999, and the regulation was ready to be enforced in 2000. That's something remarkable for Latin America context, since regulations can be delayed, say, 6, 7, 10 years after the law implementation is enforced. So we saw something remarkable there. And the other period that was statistically significant about the increase, not just linear, but with some other co-founders, took into account 2004 and 2005. We hypothesized that it would probably be related with the regulation in Brazil that was enforced by 2003, where every similar and every copy that is implemented in this segment of the graph should demonstrate bioequivalence. So it's probably a way that they used to promote that these medicines were included in this part of the segment of the analysis. So that's Brazil. The result from Mexico retail sector, we saw also a linear regression. It's a little bit slower than the Brazilian retail sector and the entry of the generics. We have seen a 4-fold increase between 1999 to 2009 of the unbranded in the retail sector. And we see that the market is dominated by branded generics, and that still is going on in 2009. We hypothesized, first of all, that we found just significantly increasing in this period of time, 2005 to 2006, and we hypothesized that one of the reasons probably for this was that Mexico included in the regulations that every similar product should demonstrate bioequivalence by 2005. So no medicines could longer be registered to get into the market if they don't have bioequivalence studies. So that could probably promote the generic entry in the market. As we can see from that period forward, the average generic medicines volume increased 1.31% per year from 2005 to 2009. while before 2005, the mean annual increase was only of 0.16%. So after our qualitative analysis, we found that both countries had the same goal to achieve, that to implement the generic entry in the field of the retail sector, but they use very different strategies to do so. So we included in the analysis 5 strategies to analyze a little bit further. So first of all, that was very different between these two countries was the WHO guidelines. Brazil applied these guidelines. With guidelines, we are talking about recommendations that the organization does to include a national drug policy and how it could be applied. Just an example, Brazil uses the essential medicines concepts and approach. While Mexico didn't apply these guidelines, Mexico doesn't have an explicit drug policy. The regulations, norms, and laws regarding medicines are fragmented between several institutions, several public institutions. Another great difference in the strategies was that all generics are bioequivalent. Brazil said so since 1999. But Mexico had a little bit different approach, because Mexico divided the definition of generics in two. They divided generic interchangeables and generics, and when they talked about generics also, only, they talk about also similars, copies, and so on. So that was a little bit different. Mexico just included the definition of a generic as a bioequivalent product since 2005, and that was enforced in 2010. So that was another difference. Another strategy difference was the highly positioned in the policy agenda in Brazil. The drug policy and the generic entry was highly positioned. The presidential candidature back in those years, one of the premises of his campaign was to include the drug policy approach. So the Ministry of Health was behind this implementation. In Mexico, as the policies are so fragmented, there's no champions to endorse this recommendation and to push for a more energetic generic entry. Regarding medicines regulatory agency role, in Brazil it's called Anvisa. It's dedicated to medicines only, while the regulatory agency in Mexico, it's called COFEPRIS, and has to deal with sanitary risks in general, so their efforts are unfocused. Anvisa is highly positioned in the health agenda, while COFEPRIS is low positioned. And Anvisa has financial support to promote generic medicines, while COFEPRIS doesn't have that kind of approach and is really overwhelmed by responsibilities because they have to deal with so many issues. And another quite strategy different was the national pharmaceutical industry. In Brazil was a key player in supporting the policy. The government and the industry find ways to aim and help each other in this effort. While in Mexico, the national pharmaceutical industry is very fragmented. It's not an active player and is very influenced by the multinational pharmaceutical industry, so it's very, very difficult to have the same approach in both countries. So our study conclusions were that even though both countries had similar political objectives to promote generic medicines, the strategies differed largely. Brazilian pharmaceutical policy is highly placed in the political agenda, ensure the technical, logistical, and financial preconditions for medium and long-term implementation of the policy, and key stakeholders from the private sector supported the initiative. And Mexico targeted more effectively generic utilization in the public sector, but was not successful in the retail market. I hope these results will be useful for our discussion ahead under the premise of promotion of distributive justice to ensure access. I think comparisons between countries are a powerful tool for lobby and advocacy activities among our governments. I encourage its utilization and systematic follow-up. I'm at the moment working with the Center of Assessment of Pharmaceutical Practices at the Boston University School of Public Health. So any ideas for discussion for future projects regarding policy implementation, I'll be more than happy to have with you. Thank you very much.
Thank you very much, Rene. That was a very stimulating and interesting presentation. And thank you again for sticking to the time.
Yeah, so we are good in time. We have one more speaker. I'm asking Vera, Lucia, Edais, Pepe from ENSP Fiocruz. And maybe you have to start with telling us in one sentence about Fiocruz Foundation. I don't know whether everybody knows about that. Thank you.
Well, good morning. I thank ISUM organizers for being here. Fiocruz is a research institute of Ministry of Health, and it have many others establishments. We have a national school, we have industry, a public industry of medicines and vaccines. We have the National Laboratory of Control of Medicines, and we have 2 hospitals, one of infectious diseases and another one, a tertiary hospital of pediatrics and maternal and infant health. So my work is about health litigation and new challenges in the management of pharmaceutical services. Pharmaceutical services have gained importance in the Brazilian health system after the establishment of the National Medicines Policy. It has been reinforced in the first National Conference of Medicines and Pharmaceutical Services and in the National Pharmaceutical Services Policy. PS were assigned as a specific funding block public in health system with 3 components: the basic medicines, strategic medicines, and specialized medicines. This one with diagnostic and therapeutic criteria established in therapeutic clinical protocols and guidelines of the Ministry of Health. Despite efforts and progress in PS, there is still a portion of Brazilians who are excluded from access to medicines. As a result, legal actions have arisen as a means to guarantee access to these technologies through health system. Oh, I'm sorry. The number of lawsuits and the costs of medicines granted in judicial orders is growing up at a faster rate every year. The federal expenditure with judicial orders to provide medicines reached about $1 million in 2005 and about $5.5 million in 2010. This work proposes to better understand one of the aspects of health litigation, namely the growing use of lawsuits demanding medicines and the relationship between this phenomenon and pharmaceutical services management in Brazilian health system. Health litigation is a we did a narrative review. I'm sorry. And selected articles, dissertations, and theses from databases, the Lilac, Cielo, and Portal of Theses. And we considered descriptive research, and we discussed the main elements of medicines litigation examined in light of their interference on the activities of the pharmaceutical services cycle. And we propose measures for helping the decision-making process by health managers and professionals of justice system. We found that health litigation is a multifaceted phenomenon, and literature postulates 3 possible negative effects. The first one, the absolute deferment of medicine demands by the judicial system, deeps inequities by favoring those who have more possibilities of accessing the judicial system. The second one, difficulties in the management of pharmaceutical services. The intensity of litigation may interfere with the fulfillment of the activities of the pharmaceutical services cycle. And health litigation exerts pressure on the market approval and medicine selection. It hampers forecasting and procurement, and health managers tend to create a parallel structure to respond to judicial and administrative demands because they are so big that they cannot do it in a regular way, using makeshift procurement procedures resulting in more expenses in acquisition of medicines. The last negative effect concerns to patient safety. Non-rational prescribing and use of medicines, especially when there is a prescription of a new medicine or new therapeutic indication for which there is no established scientific evidence. Decision-making in the wake of lawsuits is complex, involving elements that reach beyond technical and administrative factors. Careful analysis of medicine's prescription with underlying the judicial order constitutes an important limitation related to the use of the courts in ensuring access to medicines. This figure shows the decision-making flow we developed resulting from lawsuits, considering that medicines must be provided with the best available evidence in efficacy and safety vis-à-vis its therapeutic indication. It presents possible mechanisms to be adopted in decision-making by managers and professionals in both health and justice systems. The analysis of the case helps to establish if the demand is due to pressure to or delay in incorporating the medicine. It is important to consider the market approval, registered clinical indication, the presence in published listed funding of medicines, the existence of therapeutic alternatives and public funded lists, clinical protocol, and scientific evidence for clinical indication. Health litigation spurs many challenges to the management of pharmaceutical services. Performance of health managers and decision makers must be adjusted to new administrative and legal boundaries. Their actions must also be efficient in responding to ongoing lawsuits, as well as in avoiding additional litigation and in upholding principles and directives of the Brazilian health system, which are equity, universality, and comprehensive health care. It is necessary not only to identify the difficulties which lead to legal action, but also to create conditions for the health system managers and for the legal system to operate towards developing strategies, tools, and mechanisms to improve PS and to reduce the intensity of litigation. So the goals for PS managers are good access to essential medicines, including alternative treatment, information for patients and prescribers, and possibly limit to public funded medicines. It's necessary to pact with various stakeholders, society, patients, law managers, and judicial system. We developed two instruments. One of them, a CD with all the norms of interest for PS, and another one, we developed 30 indicators to evaluate and monitoring the lawsuits in Brazil of medicines. And we are training health professionals and judicial professionals with these two instruments. Thank you very much.
Thank you, Vera. It's a very interesting perspective. So we are very much on time, having finished with the 4 presentations. Thanks to the presenters for being so disciplined. This is fantastic and a good role model for the coming sessions. Now, this is a working session, so it's not just that you listen to the presenters and then walk away. Now we have another hour for discussion, and we as moderators have been briefed that the organizers are expecting a outcome from the session, which is basically 3 bullet points. First, and the rapporteur here is the person who has to later on be able to write it down and deliver it, so we want to try to make her job as easy as possible. So the first bullet point would be, what do we know? Yeah? What did we learn from the work that you did? The second one is now from us to develop as a group. What are recommendations for policy that we can draw based on what we know? And the third point is, what is it what we don't know, and can we formulate maybe 3 research questions based on what we don't know? No? So I would encourage you to come forward if you want to participate in the discussion. I just want, with 1 sentence, maybe just reflect back on the presentation, so to freshen up your memory, and then invite you to post questions. I guess we will probably collect 3 or 4 questions at a time, and then play them back to the speakers in order to respond, and hopefully, despite of the large room, get some informal dialogue going here. So I think from the first presentation, what I heard is that there is a largely unrecognized and underestimated, underreported need for palliative care out there, and actually growing, in particular in the developing countries with the aging populations. So from developed country like Australia, there are some approaches how this can be tackled, how this can be managed and integrated in the healthcare system. But the question is, what can we advise the low and middle income countries to do about that particular problem? Again, it is something that is not necessarily good news and probably difficult to sell to the donors, but it's a large problem in terms of human suffering. Second presentation, what I took away is that it's a big difference whether you collect rational use information in a study once a year, which has 0 impact on the behavior, or whether you set up a system for actually continuous monitoring based on data reporting, and you create a little bit a name and shame environment where people who do not report are being exposed, which obviously has an impact on rational use. So I think this is an interesting finding, an important conclusion that can be turned into action relatively quickly. Third presentation is interesting differences between Brazil and Mexico in terms of uptake of generic drug policies. I personally have a lot of follow-up questions here, but I want to ask you to ask the questions first, and if then any other questions remain unasked, then I can still step in later. And the fourth presentation shows us the impact that litigation has. And for me, I mean, I heard that when I talked to our Latin America region colleagues within the World Bank. I hear this is not only Brazil, this is many countries in the region, but it seems to be somewhat specific to the region. And I think I would say as maybe an unintended consequence of pushing for including access to medicines into the human rights basically in the Constitution, without having the legal framework that is kind of waterproof in terms of how this is being applied and delivered in a very technical environment where you have to have a mix between scientific and economic parameters. So I think this is a problem statement, and we are invited to think about how do you deal with it? What can we recommend these countries in moving forward, because it's pretty disruptive to the overall policy process and absorbing a lot of resources, human resources and financial resources. Okay, so now it's time for you. Ask questions. I don't know whether we have microphones. Yes, I think we do. Huh? So then please stand up so that the lady with the microphone can find you, and let's just do 3 questions at a time. We have time until 12:15, so we have exactly 1 hour for a discussion. We are good.
Thank you. Excellent time management. Thank you very much. My question is broadly, but specifically for Debra. Palliative care, many issues. I'm a former FDA drug regulator, so I look at it from an adverse event perspective. Clearly, you talked about abuse, people that abuse these products.
Could you introduce yourself quickly? Just
thank you. I apologize. My name is Peter Pitts. I'm with the Center for Medicine and the Public Interest in New York. Those who abuse drugs clearly have adverse events, even though they're abusing the drugs. With palliative care, there are many polypharmacy issues, so it's hard to suss out where the adverse event is coming from. And lastly, the issue of narrow therapeutic index from generic to generic relative to the manufacturer. So my specific question is, how are you sussing out where the adverse events are coming from to better determine which products are, how do you determine the kind of the safety efficacy balance?
Thank you very much for that question, because unfortunately my last 2 slides didn't appear, and one of them related to the pharmacovigilance type of work that we've now progressed into. And certainly, as you've highlighted, in this area of patients with chronic disease as well, in 2007 we did some research which showed on average in a population of nearly 900 palliative care patients, there was the mean number of drugs was 5. Last year we did some work and it's increased in 4 years to 10, and that's across 4 states in Australia. And what we're seeing is, yes, a combination of a large number of medications used for cardiovascular disease, respiratory disease, and there's people are continuing on those drugs and then having the medicines added for symptom management to those drugs. So polypharmacy, as you've highlighted, is a big issue. So what we've done is we've instigated alongside our phase 3 studies some phase 4 studies to look at those interactions. They're ongoing at the moment. It's important to say across the studies we've randomised over 600 patients to the palliative care studies, which make some of the studies the largest randomised controlled trials. And we've also established a rapid pharmacovigilance monitoring system which is extending into Asia and New Zealand and Australia. And we're trying to capture that information in real time and to develop some registries looking at those combinations. Some new drugs that are coming onto the market, we've been able to look at some parallel monitoring, because when you look at the literature, and probably from your perspective as well, in the past there's not been a lot of emphasis on pharmacovigilance in palliative care. But certainly we're starting to look at those issues, particularly with new drugs in the setting as they come onto the market. And we've seen some quite, important adverse effects associated with bowel perforation with new drugs that do have implications for both patient suffering, but also in how we fund those medicines, whether we list them and in what conditions we might list them. Because that was the other slide that dropped off, is that one of the outcomes of this policy has been to develop a palliative medicine schedule within our publicly subsidised schedule within Australia. So, and I just really wanted to emphasise the main point, I suppose, is that it was integrating the National Medicines Policy with the palliative care strategy so that you don't have things happening in silos, and that the palliative care group are really looking at quality use of medicines. And the last point you said was around unsanctioned use and diversion, because in our country, a bit like in the United States, there is significant now, we've reached that tipping point like the US, where we have more deaths associated with prescription and narcotics. And so we're having to be, so we're putting alongside of that quite a lot of quality use of medicines, increasing medication review processes, but they are in their early stages at this stage. So one of the good outcomes, I suppose, has been a workforce across Australia in palliative care being much more conscious of medicines issues and quality use of medicines, which hasn't really been part of their universe really up until now. It's been more focused on perhaps overemphasising efficacy rather than understanding harm. So even though I had a short presentation, I've answered a long question, so thank you.
Thank you very much for that. I'm sure it's very comprehensive. We'll take the next question. I think somebody already has the mic. Okay.
I do. I'm Chirag Zondlovu from Zimbabwe. I chair the National Medicine and Therapeutics Committee. I have a question for you on palliative care. One of the things I was sort of thinking about when you were presenting is the fact that palliative care medicines have given us a bit of a headache on our guidelines, because if you apply the essential medicines concept and you classify your medicines using the Venn classification, they really drop out of the priority list. And I'm just wondering, given what you've just said, how we can improve access to those palliative care medicines, because using our current system, they would be falling into the necessary or non-essential medicines in terms of priority, and we will not really have access to them.
I think Richard thought it might be a group question. Yeah.
Do we have additional questions on palliative care for now? Okay.
Aukje Mantel, Utrecht University. I was wondering, maybe you're still in the progress, but in the end I think that improved access is what you aim for. So is there any evidence that this approach really leads to improved access to palliative care medicines?
Should I answer the first question?
Any more questions for Debra? Back here.
Thank you. I'm Lily Ziganshina from Russia. And nowadays in Russia, palliative care is just being developed. And the risk here is that it is being really used and perhaps abused by pharmaceutical companies. So the question is, what is the health outcome measure for this strategy, and how do you manage the conflict of interest? You are entirely funded by government. So which medicines which fall out of the essential medicines concept as just was mentioned? So how do you deal with this? I think very challenging issue. Thank you.
And one more question.
Brian Goldman, Karolinska. Thank you very much, Debra. Just staying with this one for you and then the others later on. I was conscious nobody else has picked up on the fact that you've got government-sponsored clinical trials. I know now of several countries have introduced that. We have that in the US through the Comparative Effectiveness Programme. We have it in the UK now. We've had it now for a number of years. Sorry, we're also wearing my UK hat on. I think the government and the charities fund something like £1 billion a year into government-sponsored and other studies. And also in Italy, where I also worked, the government put in a programme whereby 5% of all promotional expenditure goes to fund government-sponsored studies. So now we have at least 4 or 5 countries. So do you link up with them? This is a sort of a question also for the panel for the future, is perhaps we should link up all these government-sponsored studies in different countries to see, hey, can we put in our patients into these studies? And can we coordinate efforts so we're not actually duplicating studies with our scarce resources? So my question to you is, actually, do you do that in Australia?
Yes.
Do you contact the other countries?
Yes.
And can we formulate that into a formal policy later on to say there should be cooperation so we don't actually duplicate studies, we actually get them filled as quickly as possible to get the questions answered?
Thank you. Well, I might take them then in sort of reverse order, if that's okay. Certainly with the Palliative Care Clinical Studies Collaborative, which is the PACS initiative that's funded by the federal government, it does have an international approach, and certainly Professor David Currow, who is the lead investigator for this work, has certainly engaged with some of the Scandinavian countries, Canada, and has been certainly active in the Asia Palliative Care Network because, as you could imagine, to undertake randomised controlled trials in palliative care, the reason why they haven't been done is because they're hard to do. And so in Australia, a small country like Australia, we've had to involve all of the states of Australia in this, and now internationally. And similarly, the pharmacovigilance work that we're just on, starting, that's also international. But so certainly would welcome that as a strategy to make that a more integrated and formalised approach. But it needs to be like that because it comes back then to your question, which is funded by government and publicly subsidising these medicines. But I suppose one of the things in this work is actually funding medicines that work. And in palliative care, because we have a paucity of good evidence-based information, a few years ago now, under the auspices of the Cancer Control, WHO Cancer Control Group, a modified Delphi approach was undertaken internationally to look at developing a priority list of medicines for palliative care. And for common symptoms that are managed in palliative care, the consensus was there was no evidence for some of the drugs that were being put forward, and so they lay sort of to the side. But a group of medicines, and it's been published, that list had gone up to WHO, trying to look at an essential medicines list for palliative care. And as you can imagine, there are some medicines like dexamethasone which will be already on other lists, and so that's the same as our list, if you like, in Australia. Well, we already have a very comprehensive public subsidy of many medicines like the analgesics, morphine, and we are lucky, I suppose, in that sense. But there is a list that WHO have been progressing. But the importance is that we progress a list that has evidence to support their use, rather than costly drugs that might not have any evidence for efficacy and actually evidence for harm. So we have that as a challenge. And I suppose that answers your question a bit as well. And your question, I might need to be reminded of the first part of the first question was around the essential medicines list, yes.
What I was saying is that if you apply the essential medicines concept to, then the PC medicines tend to fall out when you classify them in terms using the Venn classification. That's correct.
And so I suppose the first part was that work, and I was involved with that under the auspices of WHO, looking at trying to develop that medicines list. But I think as we come to look at that issue more, we do need to do some more work in that area around the palliative care medicines and looking at the fact that they do fall off the essential medicines criteria, and the fact that the list that's out there at the moment, for some of those drugs, it's hard to justify their inclusion based on the limited amount of evidence that we have to support their use, and also from a cost effectiveness point of view, and from a risk minimisation or harm minimisation point of view. But it also leads to, though, unintended consequences when people don't invest in cheap morphine and purchase other expensive opioids, or that can lead to considerable harm, not only from the drug itself, but from the fact that an appropriate medicine hasn't been made available to that community, and the suffering that and distress that entails, and the flow-on or cascading costs that palliative care has then on that community and beyond the death of the individual. And I think we often don't take that into consideration when we're thinking about some of those issues.
I just want to capture this as a potential research question. Are the essential medicines criteria appropriate for the palliative care issues, or is there a need for some adjustment? So that's maybe an outcome that we can take away from here. I think there was one more question on the industry and conflict of interest. Did you answer that?
The industry and the conflict of interest. I suppose it's interesting to be asked that question, because I suppose in establishing it in this way at arm's length from industry, where all of the protocols have been developed by the investigators, but industry is part of our national medicines policy. They are important in terms of being sponsors for the medicines if they are to become publicly listed. So they have been engaged in that sense, and they were certainly members of the Palliative Medicines Working Group who contributed to the discussions, because to engage with industry positively at the beginning, because many of the drugs don't have an indication for palliative care. And as we know, the pipeline for new drugs might be 15 years. Industry need to be thinking about a palliative indication early in the trajectory of that development phase. And so certainly as part of the Palliative Medicines Working Group, as a stakeholder, then those discussions have been able to take place in that sort of positive environment. And as I said, within the framework of our national medicines policy. But the protocols have been developed independent of industry.
Thank you very much for those questions and the responses. May I request that you switch off your mic, please? Thank you. We will encourage some questions for the other 3 papers that were presented. I see several hands already up, and I will encourage perhaps somebody who has not spoken before to start the question. Please introduce yourself and identify which of the 3 presenters you're addressing your question. We will ask, somebody has already stood. Thank you.
Thank you. I'm Arti Patel, and I've got more of a comment both to the presentation from Brazil and Mexico and to Jennie Leitz in Namibia. I think what I took back from the Mexico and Brazilian presentation was the important role of the political champion in Brazil. There was a presidential nominee, and I think he championed the generic medicines policy. And that showed as well the increase in the uptake of the generic medicines. And then in terms of Namibia, Jennie, when you talked about your pharmaceutical management information system, you introduced one, or you tried to introduce one earlier, and that didn't actually work because you then had to spend more time in terms of getting the buy-in. And I think what I'm trying to emphasize, or what we're trying to learn from these 2 experiences, is that often we look at implementation from a technical perspective, but the need to actually make sure that you are looking at the environment that you are in and the role that other players actually play in terms of the success of the policies that you actually implement. And I think if I'm in Namibia, what we've actually seen is that you've actually integrated that PMI-MS into your regional management structures and also into your national structures. And I think, how do we ensure that when we are undertaking implementation, that we actually allow for these sorts of processes to take place? Thank you.
Okay, there's a gentleman at the back there. Okay, we'll come to you after that.
I'm Gir Mohammad Ishaq from University of Kashmir, India. Since this session is on the pharmaceutical policy process, and Jennie Leitz mentioned that empowering at the regional level and decentralization of powers has yielded good results in Namibia. My comment is that regarding in big countries like India, where there are many states, one national policy does not suffice. There ought to be several state-level policies. But the problem is that there are several deficiencies and discrepancies in the state-level policies also. While as the national policy mainly addresses issues like import, export, R&D, and pricing, the issues which we are discussing here, like that of availability, accessibility, quality, safety, and efficacy, they are more looked upon at the state level. Can we recommend more emphasis in research on state-level policies in large countries, wherein emphasis could be laid on the discrepancies, deficiencies, and more robust policy issues, policy parameters, so that these issues could be tackled very well? Thank you very much.
Thank you. I think that's an excellent recommendation. I hear a recommendation more than a question, but we'll ask the speakers to comment on it. There was a gentleman here at the front. Yes, thank you.
Thank you very much. Just to commend Jennie Lates for her very lucid presentation. Now, just following an earlier question relating to the consultation, the wider stakeholder consultation. Well, I think this is something very important regarding policy implementation and one of the reasons for policy failures or implementation failures. Now, how wide was this consultation? And on which side? Because you're on the ministry side. How wide was this consultation? Can you just please, elucidate, what you really did regarding the consultation? And also regarding the integration into your health system, that is pharmaceutical system, have you been able to fully integrate it into the pharmaceutical system of Namibia? Thank you.
Okay, shall we maybe take those? I see two more hands. Okay, we'll take these two questions, then we can ask the presenters to respond to those. This lady and the gentleman here. Thank you. Richard will be in the next round of questions. Thank you.
Thank you very much. My question is to Jennie. I was really very much impressed by the effect of drug and therapeutic committees in Namibia. And my questions are very practical. So who pays for the extra work of the members of the drug and therapeutic committees? How the conflict of interest is managed? And you mentioned a number of indicators. What were the health outcome indicators? Thank you very much indeed.
Okay, this last one, then they'll respond to those ones. Thank you.
Yeah, thank you. Mine is more of a comment. I did observe that...
Sorry, may we ask that you introduce yourself? Thank you.
Sorry. I'm Francis Kalemera. I come from Namibia. I'm the coordinator of the Therapeutics Information and Pharmacovigilance Center. I noted that the presentation from Mexico highlighted something very important. As the lawsuits were coming into play, it appeared to improve the system because according to the diagram that was presented, it appears that the pharmacists, or basically the team of healthcare workers, focused more on robust medicine use, so that when a medicine is selected for management of a patient, there is a very strong background and basis. I just want to ask a question on maybe the guidelines of treatment of these conditions. Where do the guidelines come in, and this robust system? Is it based on the guidelines? Because the guidelines exist, and now there seems to be a more robust system to ensure that the medicines selected are correct. I hope my question is clear. Yeah.
Thank you very much. We hope the presenters have been noting the questions, and we request for very brief answers so that we can allow for another round of questions. Thank you.
Thank you for the questions and the comment, Arti. I don't think there was any answer needed on your comment. I support your comment. Regarding the situation in larger countries where you have many diverse states, I actually disagree that you should have a policy by state. Personally, I don't work in a large country. I have not worked in a very large country with very diverse situations, but the way I understand policies, they are at that higher level. And if I look at my national medicine policy that we have in Namibia, you're saying you want the items available, you want them to be safe, you want them to be accessible. And I don't see how that should differ from state to state. Maybe the way you implement, your implementation would need to be different from state to state, I can understand. And you empower the people at state level to really do what they need to do in their area, because it could be very different from place to place. But I would not personally advocate for different policies within one country. On the issue of wider stakeholder consultation, how wide did we go? Okay, as I introduced Namibia, we're a small country. We have a very centralized system. We don't have that many different stakeholder groups. The government is the leader. The Ministry of Health and Social Services is the custodian of health, but also the main implementer. Public health facilities are fully funded by the government. We have some faith-based organizations, but they receive their funding from the government. So it wasn't a big issue to bring them in. We supply their medicines, we pay for their staff and all those issues. So we have policies and systems we put in place, they cover the whole public sector. And that makes a huge difference compared to other countries. I've worked in Papua New Guinea, I've had interactions with many other countries, and I believe that is one of our strengths in Namibia. We consulted with the pharmacist assistants, the sub-professionals who work in the pharmacies. We asked them what areas they thought were very important to be assessed. We consulted with the pharmacists at the National Pharmacist Forum. We then brought together a technical working group, which had representation from regions, the medical stores, our development partners, and the pharmacists at national level. And the National Referral Hospital was the chair of that. And then we had a national consultative stakeholders meeting where pharmacists and pharmacist assistants came and gave their input on what we had drafted and really panel beat that so that we agreed. Because of course when you say, okay, we're gonna collect information, people start saying all sorts of things, but we really had to look at what is practical, what data is available. It's not going to be a very big workload additional on the staff. Of course there is some additional workload collecting data, but we try to minimize that. Fully integrating it into pharmaceutical services, as I say, I think that luckily within our system, pharmaceutical services is quite a small system. We have a division with only 3-4 subdivisions, and we've just built it in, and it's run by the subdivision National Medicine Policy Coordination. They do the follow-up for the data that needs to be collected. They send out templates once a quarter, and they're the ones that compile the national feedback reports. Therapeutics committees and who pays for them. These are all government employees. Nobody pays for therapeutics committees. We did at one point give some support through development partner funding. And at this point in time, we're struggling to get the regions off asking us to pay for catering for therapeutics committees. And it's like, no, that's your own business. This is your routine work. Conflict of interest, we don't have industry involved in therapeutics committees. We hardly have industry in Namibia, which on this side is beneficial. On the other side, availability of medicines is a disaster for us, but we import all our medicines, so we don't have a major issue of conflict of interest. You get the professionals sitting down together and discussing their own issues. Health outcome indicators. Okay, I am not quite sure what you mean by health outcome indicators. We basically moved on from looking at what we were doing with the National Medicine Use Surveys and took some of those issues forward and added other areas in. We look at indicators about inventory management and availability of medicines. We look at quality of care indicators. We look at financing indicators, and we look at HR and workload indicators. I have the 21, so I don't think I should go through all of them here, but those are the areas that we focus on. Is that all? I think, thank you.
Okay, thank you very much for your questions and comments. Regarding the champion, I think it's the evidence, the empirical evidence we have so far in organizations on how to process these kind of things are very clear about that. The champion is one of those aspects that should be taken into account in all those cases that we want successful implementation of policies. And regarding about the guidelines and how the policy process in Brazil was different than Mexico, I think it was a very organic process. It was a very flexible process. The government was allowed to negotiate these regulations with pharmacists, with the industry, that those stakeholders were not didn't agree with the implementation of the drug policy at first, but the government and Anvisa have the ability to change that perspective and get them as allies. I think also that big difference between Brazil and Mexico that I haven't commented already is that the branded medicines in Brazil from 1999 to 2009 went down from like 50% to 30% in the market share. That's a huge amount of introduction of generics, and the exclusion of branded medicines. As we know, they could be very more expensive than generics ones. So in Brazil, that they have like 75% of coverage for people, it's a very good intake to take into account to lower prices of medicines. And also, it's very important to notice that the efforts between Anvisa and the government in Brazil were very central-oriented. They had a lot of support from civil society. We have to recognize that in Brazil, there are 100,000 citizens, delegates that work with the health government and the ministries. They have the power to decide policies, implementation, regulations. The government gives money to civil society groups to become watchdogs of what the government does. So that's a very interesting approach of doing things and taking into account human rights, and that's very different what that happens in Mexico, where civil society is a little bit weaker than the Brazilian civil society, and they are not as represented as the Brazilians. So I think those things are good examples and things that we should take into account when talking about policy implementation.
Okay, first let me welcome a group of people who follows us through webcast. From Alexandria, we have actually one comment and 2 questions from there, which I would like to read first before going into the next round of questions. The comment was, we would like to suggest that the ISIUM adopt the recommendation to develop a platform where instances of irrational use can be reported at national, regional, and global level, something similar to the system for reporting of bad drug promotion practices, not adhering to ethical codes, and so on. So that's a recommendation. And then questions to, I think questions to Rene. Can you provide more information on how the system in this country, I think both Mexico and Brazil, ensures the quality of generic medicines? And in your opinion, does the public have confidence in the quality of generic? I think that's important, it's a perception of quality, which is one important factor in accepting generic medicines. And the second question, are there any efforts to promote the use of generics, provided, of course, that it would be more beneficial to the patient, both therapeutically and economically? So promotion, the use of generics, how is this being done? Maybe you can quickly answer these questions, and then we go back to the audience for a next round of 3 or 4 questions. Oh, okay. Well, was there from the question from the previous one? I think it was about the impact of the litigation on the quality of prescribed evidence of. Oh, sorry. Yeah, we forgot that one.
The beginning of the lawsuits in Brazil was with antiretroviral medicines. It's a discussion now if lawsuits improves PS in any manner. I brought the negative effects of lawsuits, but in Brazil, and the federal expenditure, now some states have 50% of expenditure with lawsuits comparing with regular expenditure with PS. But they organize the services of PS because of lawsuits, yes. Mainly in municipalities and some states there which are not so big. And the protocols, we tried to categorize the demands, and we could identify 6 analytical categories. And they were some of them are related to difficulties in incorporation and difficulties in the management of pharmaceutical system. And then the lawsuits really improves the organization of PS in local systems. And other ones, no. Some categories were from medicines which don't have a market approval in Brazil, or with extra-bulla indications. And we did, therefore, some studies, and we identify that the trials in Brazil, some of them were for these medicines to these indications, and we found 2 patents deposited for 2 of these extra-bulla indications out of Brazil in the United States, and 1 of them in Brazil. So for one side, it improves the organization of pharmaceutical system, but now it interferes with pharmaceutical systems on the management of pharmaceutical systems, because we have about 70% of medicines that is not in founding lists. We have walked through the organization of pharmaceutical system, and now the discovery of the use of judicial systems is more prejudicial than benefic. And the guidelines were improved and developed and actualized. We had some guidelines that were from 202, and last year the Ministry of Health made a lot of, we have almost 100 protocols, clinical protocols. They are especially dedicated to the specialized medicines, which are the higher costs medicines, and to the treatment of hair diseases in Brazil. So one of the things I think it can be a recommendation is to have guidelines to the principal diseases of the burden of disease in each country, that leads from the basic to the more tertiary care with this disease, for example, to diabetes, since a protocol who goes since the basic treatment for diabetes till the patient who is hesitant or cannot use the first and second indications. Because we have in Brazil a problem that is, as we treat more or less in basic treatment, we have a lot of transplant, and we have a lot of problems with that we could be avoiding if we had treated so well in basic indication. So I think it's it. And sometimes the demands, for example, one of the categories was from medicines which are not so indicated of a third line, but we had no treatment, alternative treatment in the list, in funded list at that time. For example, they demanded travoprost for glaucoma, but we had no medicines for glaucoma in the protocol. So Ministry of Health made a protocol for glaucoma, and we insert timolol in Rename for glaucoma because we didn't have. So sometimes it helps to organize, yes, the system. Yeah. Okay.
Yeah, let me, I give the two questions to you so you can refer. These are the two questions from Alexandria.
Thanks for the questions. First of all, if we talk about medicines, I think we should be aware of three important aspects of medicines. We should be aware of quality, efficacy, and safety. In terms of quality, I think Mexico and Brazil do a good job in following international standards. They follow good manufacturing practices, so I think it's safely to say that they have good standards to ensure quality. In safety, that's the same case, and efficacy, that's another aspect. Only interchangeable generics are proven their efficacy and effectiveness, and the similars, the copies, and that segment of the market share that I showed doesn't have that bioequivalence, so the efficacy is not proven. So that's a thing that we should be taking into account. About the confidence of the generics in both countries, I think back in 1999, both countries have had similar perceptions from the population about generics. The perceptions were not very good. They thought they were substandard products. And Brazil has been more effective to prove and to promote that the generics are as the same quality as branded medicines. And I think, if my memory doesn't fail, in a research study that was done in 2008, the perception that the generics were of good quality surmount like 70% of the population that was interviewed. In Mexico, that's a very different issue. The public still thinks that the generics and the products that the public sector offers, the interchangeable generics, are substandard quality. I think that's in part because the multinational pharmaceutical industry have more power and more resources to still promote that the branded medicines are better. And that raises to me a question about the efficacy and if we should be proving that the efficacy of medicines should be taken into account, especially with the least developing countries. In the case of Latin America, Mexico, Brazil, Chile, and Argentina is trying to include bioequivalence guidelines, bioequivalence regulations. The other countries are or still implementing or doesn't even have a regulation framework in order to prove efficacy. So that's, I think, a hot issue to debate if least developing countries deserve the right to know that their medicines are bioequivalent and they are effective. I think that could be a research question. And economically, we have studies in both in Brazil and Mexico. I know from experience that the generics can be 10 to 20 times less expensive than branded medicines. And we have done a research in Mexico regarding availability, prices, and affordability of medicines. And the difference between prices in branded and generics was enormous. Just to give you an example, fluoxetine in the Mexican capital, the DF, fluoxetine in branded medicine was 178 times more expensive than the international price comparison. So it's really a problem that the branded medicines in Mexico are far expensive than generics. So economically speaking, the generic uptake is a very good method to approach in order to reduce prices.
Yeah, I think make a quick comment, and then what we would like to do is like a last round of questions. We have about 15 minutes to go, so then we take another 3-4 questions. Short, please, and short answers before we let the 4 speakers give each a very quick wrap-up and recommendations and research questions. No?
Thank you. Just answer to your question earlier about the number of health facilities we assessed in the latest report for the Q2 of 2011-2012. We assessed the data came from 145 facilities. So that's 34 district hospitals, and the rest are clinics and health centers. It's not the clinics and health centers are presenting information for all of the indicators, but at least one indicator they provide data. And just a follow-up question on the issue of prices for Rene. Did you monitor the effect of the increasing competition from generics on the cost of the branded medicines? Because we have noticed in our market in Namibia that some of the branded medicines are even coming cheaper than the generic now. Some of them, there's still a big difference, but because of increasing generic competition, the brand prices are coming down. I just wondered if you'd had a chance to see that.
Okay, we'll take the last round of questions, then Rene can combine with others. I see many hands. Maybe we start with Richard, and then I see about 5 hands. Ooh, there are many.
I'll be very quick. It relates, the first thing, Jennie, you presented pre-post 2007, 2011 data, and yet you are doing serial data collection. It seems to me that it would have been more impressive to have seen a time series, a series of indicators. And I wonder if you've done that, and if you haven't done it, why not? What's the problem? Because it really does seem for other countries to copy what you've done, but report it in a time series. And then coming to Rene, a similar methodological question, and it comes to the price. Your charts, I think, were IMS standard unit data. If you had done the same chart, not by volume, but by value, wouldn't you have got far more impressive results demonstrating the potential savings from the different prices? And the bottom of your charts were the originator medicines. And what I think Jennie is referring to is some of the originator medicines are actually being underpriced in relation to generics, particularly products like amoxil, which is an originator product. The GSK is marketing very aggressively as a generic. The same is true of their Ventolin. They are marketing that as to compete with generic salbutamol in a very effective way. So I think 2 methodological questions, time series and distribution by value as well as volume.
Yeah, we'll take your question.
Okay, thanks very much. Brian Goldman again. 3 methodological questions building on what Richard said for Rene. Firstly, one is, I know in Brazil that they've done over 100 different policies, I think, for medicines and pharmaceutical policies in the last 5-10 years. And so if you're doing, I think what you did was a retrospective observational study, not a time series, because it's difficult to put a time point regarding when you got so many policies. I know that because I work in over 20 European countries and regions on generics, and it's very difficult. You've got all sorts of policies going on all sorts of the time, so please on that. Secondly, I think it's also very important when you're talking about generics to say, are you doing generics versus originators for the molecule and for the class? You need to differentiate those. They're just not the same. So those 2 are methodological. And lastly, when you're looking at policies, please can you look at national policies, this is particularly in Brazil, national and regional, because you've got the essential drug list at national level, but that doesn't filter down to a regional level, so you have to dissociate your policies, national, regional, local, when you are talking about generics.
My name is Daniel Ahinfo. from Ghana. I have a small question on palliative care, which has to do with, you started your presentation with a lot of information about the problems in sub-Saharan Africa, and then you presented something from Australia. You're dealing with two contexts. I think some question has been asked about the issue about, in terms of the policy process, what do we do with drug selection? Because if we go according to the standards, probably all the medicines that we need for palliative care would fall out. The other question I want to know, or from you, or what I want to find out from you, is also, palliative care also involves a lot of home-based care and raises a lot of challenges at the lower level as well. In terms of what you have studied in Australia, what lessons, again, do you know, or can we learn for the situation for developing countries, and particularly sub-Saharan Africa? Thank you.
Thank you. Oh, sorry.
I think we'll take a few more questions before we combine. May I request the people who have not spoken, please, to speak, because we may leave out people who... And make it like half a minute, please.
Well, a policy recommendation. The concept before was governments doing large-scale randomized comparative effectiveness studies, which is fine. It's expensive. When the results come due, they're generally outpaced by clinical practice. A suggested policy recommendation might be some type of global harmonization to capture outcomes data that has, as a field manufacturer. Palliative care certainly would be a key beta site for that.
Thank you. We'll move to the back of the room, I think, and take two questions. There are two people at the back. Sorry, we may not take all the questions. We have a very little time remaining. But the speakers are available to follow up on some of the questions you may have. Thank you.
Thank you. My question or concern arises from the litigation presentation from Brazil. I'm Rosalind Kireka. I come from Kenya. We're just about to implement a new constitution which says that human rights, health is a human right. And as we're looking through at the implementation process, we keep commenting that a lot of litigation is going to come along. So I'm wondering whether is this maybe a survey question where we can look at certain aspects that we can give guidance so that litigation does not compromise a service provision, because it's going to come, we can see it, and I've now had it, that it actually can bog down the system. Thank you.
Good morning. Mine is a quick question. I'm Josephine, Nairobi. To Debbie, you talked about a rapid pharmacovigilance system. How is that different from what we know of pharmacovigilance systems and maybe what ADRA is doing in Australia? Thanks.
I think we'll take one more from the gentleman here.
So I don't have another question, just a comment, okay. Brief comment in response to Jennie's reply to my question. The dilemma in India is not that whether we should have state-level policies or not, because we already have them in place, and that's perfectly in consonance with the recommendations made by National Commission for Macroeconomics and Health, National Human Rights Commission, Standing Parliamentary Committee. Several expert groups have recommended that already, and we have that in place in many states. Because the dilemma is that there are deficiencies and discrepancies. Do we need more research into those state-level policies? Because not only policies have been recommended for individual states, even the essential lists of medicines have been recommended for individual states. And that is being implemented right now. So is there the need for more research into those key issues, the discrepancies and deficiencies at the state level? The policies are already there in place in different states. Not all of them, but in many of them.
Okay. The last question from the gentleman there, then we'll ask. Yes. Thank you.
Thank you. We've raised the issue already of the problem between the human right of access to essential medicines and the way in which some of the constitutions in Latin America are written, is there a recommendation that could come out, for example, to say that in the national constitutions or in the basic law of countries, there should be at least some recognition of a limit to access, and that countries that fail to do that are going to set up problems. My own country, I'm Andy Gray, South Africa, we have a right of access to healthcare within the constraints of available resources. So we've entrenched in our constitution the ability to ration. And we've tested that in one of the first court cases in the post-apartheid era. So I think as a recommendation from this body, that would be really important.
Thank you very much. We'll give the speakers time to respond. We were just discussing with my co-moderator where an issue has been raised to our recommendation. We request that you don't dwell on it if it's something that you agree with or you can follow up later, so that we shorten the time that we each have to respond. Thank you. So we'll take it from there, and perhaps you can also give us your wrap-up comment at the end of your answering your questions. Thank you.
I think that the questions around the essential medicines list highlight that even though some preliminary work has been done by the WHO with respect to essential medicines in palliative care, that there's more work to be done in that area. A lot of the focus has been more in managing symptoms in people with cancer, and that naturally has been the focus, but obviously palliative care extends more broadly now. And I think your point around my reflections on sub-Saharan Africa is that it's not in Australia. One of the motivations for the government funding this initiative and looking to increase access to medicines is because we in Australia have a problem with access to medicines in the community, and one of the common reasons for why people die in hospital in Australia when the choice might have been to die at home has been because to access medicines. So we have had problems, and so I think one of the earlier questions was, do we have evidence that by increasing the number of medicines that are publicly subsidised is improving that? It's too early to tell. We have seen increasing uptake of medicines on the palliative medicine schedule, but and importantly, it's the medicines for dry mouth, bowels, anorexia, nausea. These are the things that we're starting to see bigger increases in symptoms that often go unrecognised but are a significant disease burden. So it's a bit early to tell. We're not just talking about the analgesics because in our country there's relatively good access. In terms of rapid pharmacovigilance, it is just recognising that in terms of the time that we have to become aware of these, often pharmacovigilance and central detection might recognise problems that having become aware of, then we might change the labelling of products, or we might change some of our policies around that. Or if it's a person who's got a chronic illness, part of that process is to recognise and record their various adverse drug reactions. In palliative care, the time that we're looking at some of those emerging symptoms, we want a fairly rapid response, and we've just called it rapid to engage with our colleagues so that they will take part in pharmacovigilance. Pharmacovigilance previously was something they wondered how I was actually spelling it sometimes, I think, because pharmacovigilance, we say, doesn't end when palliative care starts, but perhaps historically it has. And so my final comment would be that improving use of medicines in palliative care, I think, is an important issue that has not been perhaps as high a priority, but given the ageing population that is coming towards us, those issues around improving use of medicines will not only be about managing symptoms, but how we manage their chronic diseases as death approaches. Thank you.
Thank you very much for that wrap-up. We take the next one.
Thank you for the opportunity. Richard, the question on the time series, I had time series in. We were limited to 10 slides. I could have presented a lot more than 10 slides in 10 minutes. My normal style is I flash a slide and show it. I couldn't show the discussion points and the results in that time. So if you have a look at the poster 1202, I also have copies of our quarterly reports, feedback reports, all of those, they show time series, not before and after. It was just literally being limited on the slides. I'm afraid I should have thought of that. Maybe to wrap up from my side, I'm very happy to have been here and had the opportunity to present the work we're doing on pharmacy management information system. I think it's important and it has benefited us. I think other countries can learn from that, but I also realize that we are in a privileged situation that we have a centralized system that is not having a lot of different parallel systems. We've worked very hard to keep it like that, as we've had increased donor influx since 2003 when we started our ART project. We have had a lot of people coming, trying to pull us left, right, and center to have many parallel systems, and we have refused. We have tried to keep everything aligned. We also have an antiretroviral treatment pharmacy management information system that links in with this one. I didn't talk about that, but that is another issue. And I would just encourage all people from national governments to try and strengthen the leadership from the ministry side, from the government side, and not to allow parallel systems as far as you can. And then that will assist you with all of the different issues, whether it's a pharmacy management information system or whatever, implementing your essential medicines list. The question came this morning, how many medicines are available in your health facilities that aren't on your essential medicines list? It doesn't happen in Namibia because the central medical stores doesn't buy them. At the referral hospitals, we have a few buyout items, but the other items, they're all on the essential medicines list because of the centralized system. And it doesn't disempower the regions. Some people think if you say it's centralized, then the regions and the districts don't have control. They also have control at their level. There's mechanisms in place for them to really do what they need to do, but we ensure that the national policies are adhered to. So I think that's very important for national governments to try and work on that. Thank you.
Thank you. We'll move to Rene for your questions. Answer your questions.
Okay, the first question is that if branded medicines decrease their price, regarding Brazil, I don't have the data to talk about that, but in Mexico, the situation of branded medicines, they have such a strong share of the market that they don't need to diminish their prices. So I think competition with generics, at least right now, is very fragile and it's not very, very strong. So that's something that the government is trying to address. Regarding the methodological questions, why we use volume and not value, that was mainly because we use IMS data, and that's the data that they share with us. It's a very expensive data, so we couldn't get the value data, so it's a convenience sample. I agree with you that the value would be more impressive and probably could be more useful, but we didn't have that data, so we use volume. Regarding the analysis that we did, I agree that we started with a retrospective approach. After that, we started to do the time series analysis and the correlation. We're very interested to know if there was differences between those periods. Right now, we're in the process of getting to the linear regression and the multiple linear regression in order to find if there is causality. By now, we only can say that there is a correlation. We are hypothesizing that the policy has something to do with it, but we are not sure about it yet. So I agree with you that that's not something that we could address in the abstract, but we are taking care of that. And the national and regional approaches, we have only taken into account the national guidelines, the national regulations of Brazil and Mexico to do this analysis. Both countries are decentralized and they use the states in order to deliver health, but I think also in the regional and local levels, they use the guidelines from the national levels. My final recommendations for going further in innovation and in this process have something to do with the policy implementation should be linked to impact and outcome. I think that's very important. For example, in our case, we did a really thorough investigation of the private database. We didn't have public databases available, so I think it's a very good idea for the public sector to ensure that they have data that can be analyzed and that can be shared. The follow-up of this data is crucial to make decisions. I think that's something that could be included. And another thing is we should think about innovative ways of proving efficacy in the least developed countries of medicines. That's something that is not in the high of the agendas, but I think it should be taken into account. And my recommendations for a policy-oriented approach would be that countries should take into account that national drug policies, explicit national drug policies are useful. The efficacy of medicines should be taken into account. The political agenda, the government should have a champion in order to make the things done. And the key players, the stakeholders, should be taken into account when these policies are implemented. Pharmacies, physicians, civil society should be allies of the government in order to success in these efforts. Thank you.
Thank you. Yes, in Brazil, the right to health is a fundamental right. And judges consider only this. And we have an article in our law that says this is a right and includes pharmaceutical services. So we have another thing in our law that is to be provided by politics made by the states. So it is responsibility to the state, to the government, to provide, to guarantee the right to health, mainly by establishing politics to give the access to people to this right. It is not understood by this way by the court. We have a federal country, and we have 3 different spheres of government: the municipality, the states, and federal. They didn't consider any other norm above the Constitution. Now we have this year, Ministry of Health edited a new law. And this new law, because we have 3 principles in our law for our health systems, and a big principles: the comprehensiveness, the universality, and the equity. And now, this year, we edited a new law that limits the comprehensiveness to a list of procedures and medicines that will be actualized every 2 years by government, and that constraints of some way the lawsuits. But I don't think it will. I think it will put it in another level of discussion in Brazil, because now we have a law that limits the extent of the rights. But I think one thing to limit is to have a good PS. If we don't have a good PS, that's the mainly discussion. Nobody in Brazil discusses more that the medicines which are in funded lists are right. They have to be granted. The discussion is the new medicines and that one that is not in the lists, but sometimes in a concrete case you can need it. And I think another thing is to have other ways to access to these medicines. São Paulo, which is the biggest state in Brazil, have, and all the states are doing now administrative demands. So there is now some efforts to contribute with judicial systems. So sometimes it comes directly to government, to health service, the demand not by judicial system but administratively. And in São Paulo now we have a decrease of lawsuits but an increase of administrative demands, so that this can be examined technically, considering efficacy, safety, and quality. I cannot resist to make a commentary about generic in Brazil. We have, yes, studies that shows that some of them are more costly than the reference ones, but it's not the principle, what happens more. And it was a big process in Brazil. The famous law of generic in Brazil, it is from 1994. So we have 10 years till we can really have the generic growing and being stronger as a policy in Brazil. So I think everything is a process, and we have to think it by the beginning, how to improve it and to process. And I think this, it's better to have in law a limit of what will be provided and how it will be provided, because till 202, a lot of states in Brazil didn't have a pharmaceutical service, a service of pharmaceutical service. So it was not organized. Now we have a more organized system of PS, and the costs, the expenditure in Brazil in the last 5 years increases at a rate much more bigger than the expenditure with health in its totality. So I think it's better to put it in the law, how it will be provided. Thank you.
Okay, thank you very much to our 4 speakers. I realize we had a lot of difficult issues here to tackle in these 2 hours. We went a little bit over time. Thanks for hanging in here and staying with us. I hope our rapporteur can make sense of what we discussed. I wish you a good lunch break and see you again in the afternoon for the continuation of the policy track sessions.
Que tem medicamento de referência, tem os remédios. Então, eles barateiam os remédios.